So we're going to talk about phacomatoses. I have nothing to disclose. So we want to review, we won't be able to cover all of them, there are too many. So we only show some of them. And what I want mostly to do is to illustrate some of the more recent advances that have come up either in the imaging field or at the level of the pathophysiology of these phacomatoses. Just to warm you up, here is a patient. Actually, 4 different patients who all have NF1 except one. So on the upper left side, you have an axial T2 to the posterior fossa. Image 2 is a lumbar spine T2. Image 3 is an MRA, and image 4 is a contrast-enhanced T1. So which one is not neurofibromatosis 1? Okay, that's Sturge Weber. So what were the other ones? We'll talk about occipital bone dysplasia. We'll talk about a little bit plexiform fibromas, and we'll talk about the arterial vasculopathy, which are all manifestations of NF1. It does help in understanding the imaging features to recognize the functions of the NF1 gene. This gene is involved in tumor suppression, in maintenance of vascular wall, in bone formation and remodeling. It's needed for normal myelination, and it's also involved in histogenesis of the brain parenchyma, especially at the microscopic level. It's an interesting disease also because it has a very unpredictable clinical expression. These are 2 brothers who had screening MRI exams performed on the same day, kind of back to back. The younger brother, the 4-year-old, has an optic nerve tumor, you can see on the left, and the older brother had moyamoya disease, which made for an interesting conversation with the brother's parents. So the imaging features, when I teach my fellows and residents, I always say you want to look for white matter abnormalities, you want to look for tumors, you want to look for vascular lesions, you want to look at the bones, and also I'll show you some hamartoma-like lesions that tend to occur in patients with NF1. So white matter abnormalities are by far the most common abnormalities, and also clinically the majority of patients with NF1 have cognitive issues, and these are probably related. We'll see abnormalities in volume, in diffusivity, and also the fairly well-known characteristic T2 bright lesions of NF1. So the white matter volume is increased in NF1. On average, 20% larger white matter volume than age-match controls. And this tends to correlate with the presence of macrocrania, which is seen in about 50% of patients. If you do diffusion imaging, the fractional anisotropy is decreased even in normal appearing white matter, and the ADC is elevated. And interestingly enough, of the 3 eigenvectors, the radial diffusion is the one that's disproportionately increased, which is maybe an explanation for the increased white matter volume, because the increased radial diffusivity may reflect a looser axonal packing. So the axons need more space and therefore a greater volume. The characteristic hyperintensity T2 lesions are seen in most patients with NF1, especially in the first decade, and sometimes we'll use these to help confirm a diagnosis of clinically suspected NF1. There's only one pathologic report that I know of that came out of CHOP some years ago, which showed myelin vacuolation. If you do diffusion imaging of these lesions, you find that the characteristics are those of intracellular water that has obtained extracellular-like properties, which is a bit of a strange concept. But basically, what we refer to is intramyelinic edema. So it's edema within the myelin sheath. These lesions are eventually broken down by normal metabolic processes. So if you see on a 4-year-old on the left, you see that there are bilateral lesions in the deep cerebellum, and at age 12, the lesions have gone away. So you shouldn't call those hamartomas because they're obviously lesions that come and go. In the same patient, at 4 years of age, there were a few lesions in the right globus pallidus, and then you see on the right-hand side at age 12 that there are many more lesions. And this is a very typical progression in that the posterior fossa lesions tend to appear and disappear ahead of the lesions in the cerebrum for reasons that are obviously not known. The lesions should never be subcortical and they should never enhance. Right? If you see an enhancing lesion, pretty much it's a tumor. But even a subcortical region, those should not be present. So this child had multiple lesions, you can see in the basal ganglia, but also had a right frontal subcortical lesion. And if you do screening MRI, sometimes you'll pick them up when they're only 2 or 3 millimeters in size. But this needs to be followed. So it's the same patient a year later. You can see the lesion had increased in size quite a bit and was now enhancing. And this was a low-grade astrocytoma. And pretty much all of the subcortical lesions, subcortical tumors we see in these children are low-grade astrocytomas. Which is a great segue to talk about the second most common manifestation of NF1, at least imaging-wise, which is the formation of tumors. So the NF1 gene is a tumor suppressor gene. It inhibits the RAS proto-oncogene, and cells that have a double NF1 deficiency will have abnormal proliferation and survival. And then the 4 most common types of tumor we'll see are optic pathway gliomas, other gliomas in the brain, and then all sorts of neurofibromas, and less commonly neurofibrosarcomas. These tend to be more common in adults, but we'll see some in children also. So optic pathway glioma, if you do screening MRI exams, meaning you take otherwise healthy NF1 patient children and you put them in an MRI scanner, up to 25% of them have optic pathway gliomas, so 20 to 25%. They're almost all pilocytic astrocytomas. It's one of the few tumors that the oncologists will treat without actually tissue diagnosis, because the assumption is that it's a pilocytic astrocytoma. They almost all arise before age 6. So if you're older than 6 years old with NF1 and you don't have an optic pathway glioma, it'd be very, very unusual to develop it. You're pretty much out of that window. Here's a child who had a mild amount of proptosis, but otherwise had a completely normal ophthalmologic exam. And you can see that both optic nerves are enlarged, they enhance. The chiasm also is enlarged, and it's enhancing. And it's remarkable how many of these children can have very large tumors and have completely normal ophthalmic exam. Also characteristic is infiltration of the optic pathway and even beyond. So you can see tumor infiltrating into the optic tracts, into the cerebral peduncles, and even all the way into the pons. And also typically the brain infiltration tends not to enhance, even though the component in the optic nerve and the chiasm enhances. So there needs to be kind of a biphasic appearance. Here's another child, it's a 21-month-old, completely normal visual exam, who had, you can see on the top left, tumor in his chiasm that was enhancing, but also had quite a bit of infiltration of the brain into the optic tracts, the cerebral peduncles, the thalami, and even beyond the lateral geniculate body. Here's one more case, very extensive tumor again. They're not all like this, but when they're like this, they do present some issues for us and for the oncologist. So there's tumor here in the chiasm, you can see on the left. In the hypothalamus, this tumor is actually extending up into the septum, towards the septum pellucidum along the fornices. Very extensive infiltration throughout the basal ganglia, and tumor all the way into the pons and even extending into the cerebellum. So the challenges in optic pathway gliomas is 2. One is that the tumors tend to be very extensive and very infiltrative. So it's not easy sometimes to assess their size. It's also sometimes difficult to differentiate an optic pathway glioma, glial tumor, from the characteristic T2 bright foci that you see in children with NF1. So it's not always easy to tell what's tumor and what's vacuolation. So it's hard to assess the tumor size, it's hard to assess sometimes the tumor extent. And when the oncologist comes to you and wants to know if the tumor is 25% larger in area, in surface area, which is their standard criteria to determine tumor progression, that can be an impossible task to fulfill. Now, how are we going to differentiate tumor infiltration from NF-related T2 bright lesions? Factors that favor tumor is contiguity of the lesions. As we saw in the previous case, you see how this infiltration is all contiguous. If there's mass effect, Vacuolation tends to be iso-intense on T1 images, whereas tumor tends to be hypo-intense on T1. If you see enhancement, for sure, that's tumor. That's easy. And then just observation over time. Tumors tend to grow. Vacuolation doesn't usually grow. If you can also do MR spectroscopy, that helps quite a bit. Even though these are benign tumors, right, pilocytic astrocytomas, they tend to have a very characteristic and striking MR spectroscopy with marked elevation in choline, very low NAA, and even sometimes lactate. They almost look like the spectroscopy of a rather malignant tumor, even though it's actually a grade 1 histology. Going to vasculopathy in NF1, so blood vessel that is lacking in neurofibromin, which is a gene product of NF1, tends to have abnormal responses to endothelial stress and specifically formation of or proliferation of smooth muscle. Again, in a screening population, if you do screening exams, the incidence is anywhere from between 3 and 5%, depending on which study you believe in. If the patients are symptomatic, then the incidence is even higher. What we mostly see is vascular occlusions or stenoses, and they can be quite subtle. So either you have to look for them, look at your flow voids very carefully, or you can also just elect to do MRA on all of your patients with NF1, at least at one point in time. The lesions tend to be acquired and also tend to be progressive. So here's a 16-month-old who had, at that time, fairly symmetric appearance to the cavernous portion of the carotid arteries. Maybe on the left is a little smaller, but that I think would be difficult to say. There's a vasculopathy here. Here's the same patient at 5 years of age, and now you can see a rather striking difference in the caliber of the internal carotid arteries. This is the MRA, and you see that there is a stenosis, or maybe an occlusion, even more likely, in the ICA just below the origin of the posterior communicating artery. So the PCOM was feeding the distal ICA and then the ACA and MCA. Here's a patient who actually had many MRI exams, but on the most recent one, we noticed on a thin coronal T2 that the flow void of the distal right ICA was a little smaller than the left, which then triggered us to do an MR angiogram, which shows, you see narrowing here of the distal ICA, and then a rather small A1, which sometimes hard to tell, is that just an asymmetric variant, or is there some involvement of the A1? And this is the angiogram, so you can see the distal ICA here is very narrowed, and there were some collateral vessels that you can see in the MRA. So this patient does have Moya disease. So always look, you should always look at your flow voids, but especially in kids with NF1, because they do have a significant incidence of vasculopathy. Now, NF1 is needed for normal bone formation and remodeling, so bone cells that are lacking neurofibromin tend to become dysplastic. Remember that in MRI, we don't actually see bone itself, right? So the case that I showed you showed the manifestations of absence of the bone, which is that the cerebellum and the dura on top of it tend to expand where the bone should be. It's a lot easier if you do a CT scan, where now you can see exactly what's going on. There's a portion of that occipital bone that has not formed. Now, this is the less common location of bony dysplasia. Where we see this most commonly in neuroradiology is at the level of the greater wing of the sphenoid. All right, so here's a CT scan and a defect in the greater wing of the sphenoid on the right. Here's a different patient who has a sphenoid wing dysplasia on the left. And you can see on the MRI that there is a plexiform neurofibroma of the first division of the fifth nerve. And this is a very constant. Almost all patients who have sphenoid wing dysplasias have a plexiform neurofibroma of the first division, or maybe more, but always the first division of the fifth nerve. So you can look for that at the same time. Now, a couple of lesions that sometimes can be confusing And I'm not calling them hamartomas because, again, no one has histology on these lesions, but it's good to know of. One is in the brainstem. Some patients with NF1 can have remarkable enlargement of their brainstem. And on T2 images, it looks a lot like vacuolation in that it's kind of this hazy, bright signal. There is some mass effect, obviously. But if you look at a T1, it's totally isointense. If this was a brainstem glioma, you would expect to see hypo-intensity on the T1 weighted images. And it does not enhance, and if you follow this over time, it just stays like this. And this is an old slide, but this is a patient that has been coming to us for more than 20 years, and his brainstem still looks like this. Here's a different patient with this kind of same idea, unusual thickening of the pons and even the medulla, and again on T2, very extensive kind of confluent, what I presume is vacuolation, but it does give you kind of a hamartoma-like enlargement of the brainstem. So, and then again, the idea here is you just need to follow this over time and make sure that it doesn't change, and don't send them to the neuro-oncologist because they may want to treat that. More common than that, we'll see enlargement of the hypothalamus, and again, in a lesion that kind of looks like a hypothalamic hamartoma. We've seen this in 2 or 3% of our children, so you can see on the left there's a sagittal T1, a lesion that you might think is a chiasmatic glioma because it's where a chiasm in part should be. But if you look on the axial T2, here's a chiasm that's wrapped in front of this lesion, and the chiasm is normal appearance. So this is a lesion that's behind the chiasm and in front of the mammillary body. So it's along the floor of the third ventricle, which is where the hypothalamus is. And on a coronal T2, this lesion, they tend, like any hamartoma-like lesion, they tend to be isointense, and they tend not to enhance. You can see T1 post contrast. The difference between the hypothalamic hamartomas that we see in clinical practice in the non-NF patients is that these patients do not have gelastic seizures, and they do not have precocious puberty. So it's kind of a incidental lesion. Though if you look at the cognitive profiles of these kids, they tend to be function less well than NF1 kids who do not have hypothalamic hamartomas. So there seems to be some cognitive association with these lesions. And then lastly, though this is also a little different, but good to know, the hippocampi in pediatric patients of NF1 tend to be oftentimes bright and oftentimes enlarged. This patient, you can see in a coronal flare, both hippocampi are unusually bright on flare imaging, and also even on T2, and you can see on the left side that it's a little larger than the right. And it's good to know because this is obviously not limbic encephalitis, and it's not seizure related, and it's not tumor also. And this tends to persist even in adolescence or early adulthood. So just another manifestation of NF. Okay, shifting gears a little bit, here is a patient who has a flare image on the left and a magnetization transfer T1 image on the right. And with this comes a question: what is the most likely diagnosis? Is this neurocutaneous melanosis? Is this NF1? Is this incontinentia pigmenti? Is this tuberous sclerosis? Or is this Parry-Romberg syndrome? These are all phacomatoses that can present with white matter lesions. And the answer is tuberous sclerosis, okay? And the take-home point here, if you don't do this, you should do this, is that when you do mag transfer in patients with tuberous sclerosis, you can see way more lesions than your regular T1, T2, or flare images, and it can really help in the diagnosis. So TSC, the manifestations are white matter lesions, right? Subependymal nodules, tubers, and SEGAs, the subependymal giant cell astrocytomas. So starting with white matter lesions, so radial migration line is the most common imaging manifestation of tuberous sclerosis. And these are heterotopic dysplastic neurons that tend to extend from the ependymal surface all the way to the cortex. They're best seen, as I showed you, with magnetization transfer imaging. So this is a T1 weighted image, and everything that's bright represents an area of abnormal cell, both in structure and in location. Here's a patient, this was an adolescent, and I have a few cases like this that was referred for epilepsy. Unknown clinical diagnosis was that he had tuberous sclerosis, and if you did his regular MRI, you would not have found anything to worry about. But on his MAC transfer, there were all these T1 bright lesions that showed up, and this is a child who had tuberous sclerosis. So we like to do MT imaging in all the TS patients and even in all the seizure patients, because sometimes it will reveal these hamartoma lesions. Now, tubers, we're all familiar with tubers. There's our hamartomas. They tend to be subcortical. They very occasionally enhance. Most of the time, they do not enhance. And they tend to be multiple. So here's a patient who also has multiple characteristic lesions. They're bright on T2, and they're either ISO or hypointense on T1. The challenge in the presence of multiple tubers is to identify which one might be a cause of seizure, and therefore which patient might benefit from seizure surgery. So to identify the epileptogenic zone, we have a few tools that are helpful. The best one is, if you can send your patient to Dr. Chugani in Detroit, is the AMT PET, the alpha-methyltryptophan PET. Though, if you can't do that, at least by MRI, the patients who have focal cortical dysplasia-like abnormalities associated with tubers tend to be the ones that are associated with seizures. And also, if you do diffusion imaging, the tubers have the lowest fractional anisotropy tend to be the ones that are the most epileptogenic and benefit, therefore, from surgery. So here's a patient who's got multiple tubers. The one in the left parietal lobe, you can see, is associated with a kind of dysplastic-looking cortex. Also had quite a bit of mineralization with it. But to tell which tuber is a cause of seizure, is causing the seizures, the AMT PET is very reliable. It works quite well. So this is the MT PET on that same patient, and you can see that the left parietal tuber is very hot. The other ones are not hot. Here's a different patient, and again, just to show that the tubers are associated with this plastic cortex, as you can see here in the posterior left hemisphere. Those are the ones that tend to be epileptogenic. And some people actually think that the tubers themselves are non-epileptogenic. It's the cortical dysplasia that's associated with the tuber that is the cause of the epilepsy. And those are the ones that the surgeons will want to resect. Cerebellar tubers are less common, and they differ a little bit from the cerebral ones in that they tend to be more commonly calcified, and they tend to enhance. Up to 50% of cerebellar tubers enhance. They also tend to change over time. So if you image patients during the first decade, you'll see some that get apparently bigger and even enhance more, while others tend to decrease in size and enhancement. And you have to be careful not to mistake these changes as indicative of a tumor that might be progressing. So here are bilateral cerebellar tubers. You can see there are both some retraction abnormalities and some T2 abnormalities in the cerebellum of this patient. Here's a different patient. You can see at 3 years of age, had 3 areas in the cerebellum that had some distortion of the folia and T2 bright abnormalities. The same patient at 10 years of age, now you can see the T2 bright signal has gone away, and there's more foliar retraction, almost like atrophic-like change. And that's what cerebellar tubers tend to look like. The same patient at 3 years of age, you could see, had enhancement in the tubers, and then at 10 years of age, the enhancement has pretty much gone away. So the cerebellar tubers are a little different, again, for reasons that are not well understood. Subependymal giant cell astrocytomas are the lesions that the clinicians worry about, which is why they like to screen patients with TS every 2 or 3 years. Their incidence is between 5 and 10%. Almost all of them are near the foramen Monro. And in this case, in general, size matters. So if a lesion is less than 1 centimeter, you can be pretty confident it's a subependymal nodule. If it's more than 1 centimeter or 1.3 centimeters, depending on who you listen to, then these are probably SIGAs. The distinction is important because nowadays, not just with surgery, but also the clinicians have chemotherapy that they can give to shrink these lesions. They give them mTOR inhibitors in the form of everolimus. So this is pretty obvious. On the left, there is a SEGA here. This is almost a 3 centimeter lesion. And there's a subependymal nodule here on the right, which measures about 7 millimeters. But the best diagnostic indication of a SEGA is growth over time. So if you don't see growth over time, then you should be careful calling a lesion a SEGA. So here's a 21-month-old who had a 12 millimeter lesion, which by size criteria, some people might say, well, that must be a subependymal tumor. But if you look at 9 years of age, so 7 years later, the lesion is still exactly the same size. So obviously not behaving like a SEGA. So you want to have at least one follow-up MR exam that shows growth over time before calling it a SEGA and committing the child to surgery or chemotherapy. So you want to be careful not to mistake multiple adjoining subependymal nodules for a SEGA. So if you look here on the right, there's a lesion that measures 11 millimeters, which, again, by size alone, some people would say that's a SEGA. But note that this lesion is rather narrow, right? It's not as wide as it is long. And on the coronal, same thing here, it's not very high. So this is not a SEGA. These are 2 or 3 subependymal nodules that are kind of bunched up together. And so, again, you just don't want to call that a subependymal tumor. Finally, a few words about Sturge-Weber. The angiomatosis in Sturge-Weber classically involves the face, and it almost always involves the ophthalmic branch of the fifth cranial nerve. Oftentimes the choroid of the eye, and then the leptomeninges. That would be the classic presentation. It can be bilateral in 20%. Recently, the gene that causes Sturge-Weber and also non-syndromic port-wine stains has been identified. It's on chromosome 9q, and it codes for the gene is called GNAQ, G-N-A-Q. So GNAQ mutation causes a dysregulation of endothelin. Endothelin is a peptide that's secreted by endothelial cells. And as a result of this abnormal endothelin secretion, the vessels become dysgenetic, and eventually the veins become either dysplastic or become occluded. Because of venous occlusion, you get focal venous hypertension, which has 2 manifestations. One is that the tissue that is drained by the veins suddenly will have to respond to this. And so in the brain, we will see cerebral atrophy, right? And we may see calcifications also. But also you see changes in the skull or changes in the face in the form of a port-wine stain. And also, because the veins are occluded, there's development of collateral venous pathways. So what you see is dilated medullary veins in the brain. On the right here, you can see a child with cortical calcification. So you see this kind of gyriform pattern of calcification. But more anterior, where the cortex is more normal, you see all these dilated medullary veins. And these veins are dilated because the veins on the surface of the brain have become either occluded or dysplastic as part of the Sturge-Weber lesion. Now, we get sent quite a few patients in infancy who have port-wine stains and trying to decide whether they have Sturge-Weber or not, which is, I would say, the parents and clinicians want to know about that. And early in infancy, the diagnosis can be quite difficult because the angiomatosis is oftentimes not well developed. And at the same time, the brain has not undergone atrophic change. So here's a T2 of an infant who had a left-sided port-wine stain, which looks pretty normal. On T1, there's not much to see except maybe the choroid plexus is a little enlarged, and there is some very subtle asymmetric enhancement of the sulci. A couple of years later, that posterior left hemisphere became quite atrophic, so this is Sturge-Weber, but not an easy diagnosis to do in infants. And so in all patients who have potential Sturge-Weber, you want to give contrast. That's your best shot. And in general, if you do contrast-enhanced T2 flares, those are a little better than the T1s in showing the leptomeningeal abnormality. Now, I'll show you another trick here. This is a different patient. He's 15 months old. He has a left-sided port-wine stain. He also had left-sided glaucoma, and you can see the asymmetric enhancement of the choroid on the left. If you look at the brain, again, the changes are pretty subtle. The sulci may be a little larger on the left compared to the right. Don't see much in terms of leptomeningeal enhancement. The choroid plexus is a little enlarged, which is one of the findings you see because of shifting of blood flow from the cortical veins into the medullary veins. Here's a contrast-enhanced FLAIR. Don't see any enhancement of the leptomeninges in the brain. So you might still wonder, is there intracranial involvement or not? And the answer is you have to look at the skull. So if you look at the skull here on this, this is a fat-suppressed FLAIR. You see that the skull here is thickened on the left, and I'll show you a coronal. And same thing, you have skull involvement. And when you see skull involvement, that means that there is a leptomeningeal abnormality. It's just not recognizable yet. So most infants, I mean, and older patients have this, but even in infants, if you look at a skull carefully, it's a good way to pick up early Sturge-Weber. Finally, if you do functional imaging in Sturge-Weber, whether you do this with FDG PET or if you do perfusion, either ASL perfusion or dynamic contrast perfusion, in the involved brain, you will see hypometabolism or hypoperfusion. So again, the same child I just showed you, even though the brain looked normal, on the ASL, you can see that there's a significant decrease in the perfusion of the left upper hemisphere. And in general, if you do these kind of functional imaging studies, you will find that the abnormalities of perfusion or metabolism tend to extend even beyond the areas that are abnormal as far as the leptomeningeal enhancement. So I hope I've improved your understanding of the pathophysiology and imaging features of these three phacomatoses, and thank you for hanging until